يلا 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 يا أخي قوم جميع مرض سكري يلا 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 يا أخي قوم جميع.
Je vais parler de la détection et de la prise en charge du diabète pendant la grossesse. And switch in English. Okay. As you all know, gestational diabetes is associated with maternal and perinatal complications, such as macrosomia or prematurity, and maternal complications include hypertension and preeclampsia, such also prolonged and obstructed labor due to macrosomia. And treating gestational diabetes can reduce, especially perinatal complications, fourfold. Another problem is that women with gestational diabetes have an increased risk to develop in later life diabetes mellitus, so they have a 50% risk after 15 years and even 75% increased risk after 25 years. We have a challenge that we are missing or lacking prevalence rates in a lot of countries. But another knowledge gap is really to know how gestational diabetes is detected and managed in low and lower middle income countries. When we look at the map, at the prevalence map of IDF, you see there are a lot of blank spaces on the world map. Even Morocco is blank, but I can assure you there is data from Rabat, and the prevalence has been measured a couple of years ago to be 8.2% in Morocco. However, these prevalence rates are often a kind of single-shot picture of an individual hospital, of a tertiary hospital. And you see, for example, when you look at this slide, for the Mediterranean, prevalence rate can vary between 3 to 4% up to 25%. So we don't know really. In order to learn about the practice of gestational diabetes management in lower income countries, we did a scoping review of the literature, and we looked at PubMed, Web of Science, Embase, the African Index Medicus. We screened for keywords such as gestational diabetes, diabetes in pregnancy, low income settings, manage, detect, treat, screen. And we applied no date nor language restrictions, and we found a total of 391 articles. After removal of duplicates, we were left with 256 articles. We screened these by title, then by abstract, then by full text, and finally we were left with 15 publications that had some information about practice on gestational diabetes management and screening. When you look at the origin of the papers, you can here see on this pie chart that half of the publications came from the African continent, so 2 from South Africa, 1 Nigeria, 1 Kenya, 1 Tanzania, 1 Ivory Coast. We had 1 publication from Morocco. From Asia, we had 3 from India, 1 from Vietnam, and then kind of individual publications from Libya, Turkey, Fiji, and a multiple country publication, including African, Asian, and the Caribbean countries. Also, at the base of the slide, you can see articles date back until the year 1977, so that's nearly 40 years back. We looked at screening practices, and we found out that in different hospitals various tests are used, such as for screening are used, such as fasting glucose, fasting and postprandial glucose, The O'Sullivan 50-gram glucose challenge test, the oral glucose tolerance test, either 75-gram or 100 grams. So you have a variety of screening tests that have been used. We even found in the articles that in the same hospital, different tests for screening were used in different units. In one hospital, despite using a universal approach that is actually common guideline, only 61% of women were screened. Universal means screen all women, but only 61% of women were screened. In a publication from Nigeria, they said we are having the challenge that a lot of mothers present really late for their antenatal care. So 80% of their mothers were only screened at week 28 to week 28 to week 30, although the recommended screening interval is between 24 and 28 weeks gestational age. We looked at information about hospital admission, and in 3 papers from from Kenya, from Cote d'Ivoire, and South Africa, we found they routinely admit all patients that have been diagnosed with gestational diabetes initially. In Vietnam, they did this only if glucose levels of mothers were not controllable through ambulatory control alone. And in a paper from Tanzania, they said we don't have a specific policy, we take our decisions really on an individual basis. When we looked at the hospital surveillance of those women who have been admitted, we could see that women were put on a diet that has been restricted in carbohydrates or in calories. Glucose was measured as often as 3 to 6 times daily, to as less as once or twice a week. Women received education such as diet counseling, initiation to self-monitoring of blood glucose, and generally women were discharged after 2 weeks or after the glucose values were sufficiently controlled for. We also looked at the follow-up and the ambulatory care. So in 4 papers, women were initially admitted and after that followed up ambulatory, and then in 5 publications, GDM patients were followed up only as outpatients. And the follow-up intervals ranged from weekly, twice a month, to every 3 weeks. What exams, what tests were conducted during follow-up? Normally nutritional advice was given, glycemia levels were controlled, urine tests were performed, weight and blood pressure were measured. In some hospitals they did abdominal examinations, ultrasound, and they provided information and education. In one hospital in India, they said for us it's sufficient if even the relatives of the patients come and present the lab results of the patient, because some of the patients had housework or whatever obligations, so they couldn't come. But to make sure that they see the lab results, they said, okay, it's enough if even a relative will bring us the lab results of the private labs. In terms of medication, in the majority of studies, insulin was the treatment of choice and given if diet alone was not sufficient to control the hyperglycemia. The insulin treatment was started as early as 3 days after they had modified the diet, or generally after 2 weeks of diet, and it was administered between 1 and 3 times a day. However, in 3 studies, they gave metformin. In one study from Tanzania, they said we give metformin, or we continue metformin, if the woman has already received metformin before in her pregnancy, so for pre-existing diabetes. In a study from South Africa, they gave oral antidiabetics as first-line treatment and only changed to insulin if oral antidiabetics did not work or were not sufficient to control the glucose levels. Regarding medication, it was interesting to see in one study from Nigeria, they said usually our GDM patients, 80% of our GDM patients are fine with diet alone, and only 13% would require insulin. But in their sample, they found that 40% of these women were poorly controlled. In a study from Vietnam, they said, for us, it's a problem to adequately control patients on insulin treatment by weekly follow-ups only. Regarding peri-postpartum and newborn care, there was a variety of information. In some settings, they routinely induced labor in gestational week 38, or if women were high-risk patients or not well controlled. In other settings, they said we never induce labor, we wait up to term. In some very early studies, they delivered the patient only after they have a certain pulmonary maturity by using a shake test, using some amniotic fluid and apply a shake test. But there were really early studies. We found only in one study about intrapartum management with insulin, and in that study they gave insulin intramuscularly 2 hourly during labor. Pediatricians were generally present at the delivery and assured the observation of the newborns. And in one study from India, it was written that newborns of mothers who were on medication were admitted to special nursing care and fed in regular intervals. And we got the information that women were re-invited 6 weeks postpartum for a repeat 75-gram oral glucose tolerance test, although we don't know how this worked out in practice. As on one of the posters from Morocco outside, I saw that only 20% of women came back to have their repeat testing done after their pregnancy. So I'm not sure how this worked out. The limitation of our study is, first of all, the limited number of publications from low and middle income settings. We had problems to differentiate sometimes the management of gestational diabetes from the management from pre-existing diabetes. This was not always mentioned clearly in the publication. And as I said earlier, some publications already date back nearly 40 years, so practices might have changed, guidelines have changed over time. And the majority of studies are from large tertiary hospitals. So for sure there is a publication bias that doctors from tertiary hospitals are more likely to publish their results, but also in a lot of settings, patients who have been diagnosed with gestational diabetes are referred to tertiary settings. I just want to highlight some discussion points that might come up looking at the results. And first of all, this is one point is the nutrition therapy, because when we look at the results of this study that say, okay, we have 90% of diet, but 40% of our patients are not well controlled. We have to ask ourselves if the nutritional recommendations are locally adapted. Yeah, in a lot of countries they have very carbohydrate-rich diet, and it's quite difficult for patients to purchase vegetables or to purchase a protein-rich diet because it's just expensive. Another point is insulin. It's in some countries, the availability of insulin is still an issue. The self-injection and storage in cold chain is an issue, and we found supporting information that there's a lot of fear of insulin injections on the side of the patient, but also on the side of healthcare providers, which can be explanatory for the not so well controlled diabetes in GDM patients. So in this regard, we have to stress that metformin has proven to be a safe oral alternative through randomized control trials, and it might be a more feasible option for low resource settings, especially if we cannot assure regular monitoring of patients, as metformin is not associated with hypoglycemic events. The other issue is hospitalization. Initial hospitalization for treatment might be okay. However, it comes along with costs, with direct and indirect costs, which we have discussed yesterday afternoon in the session. Then we have one big issue, and that's self-monitoring. Is self-monitoring a feasible option in all settings? As in a study from Vietnam, they applied, or they sent women home to self-monitor their glucose levels, but these women were not happy to interpret the results. They didn't know how to actually interpret the results, and anyway came back to the health center, even if it was inconvenient for them. So we have to find contextualized local solutions, such as involving private lab services or involving community diabetes support group or patients with diabetes who can support these mothers with gestational diabetes in monitoring their glucose levels. Okay. Final message, we found large differences in management, and the FIGO will announce new guidelines during their conference in October, but I'm not sure if we will have changes in management through uniform guidelines, because management need to be accessible and acceptable and really shaped according to the women's needs. So we suggest more research on local practices to address all these management challenges. Thank you very much. And just one issue. I just want to highlight there will be another big conference on maternal and neonatal health beyond 2015 that will take place in Rabat at the École Nationale de Santé Publique in collaboration with the Institute of Tropical Medicine Antwerp.